Good morning. We've finally connected the computer to the screen, which is very exciting. So my name is Russell Gundry. I'm here to talk about ecology of health, or health as an ecological concept. And in attempting to grapple with this question, the screen decides to load some photos, which is exciting, isn't it? Find ourselves in the horns of a dilemma. The best description I could think of for the apparent paradox of health as an ecology is described by Robert Pirsig, who talks about the horns of the dilemma, with the left horn being the kind of the classical view of the world, the engineer's view as everything as reducible. The elephant can only be understood as its subsystems, and if they're all taken apart and understood in pieces. And the right horn being the romantic view that the elephant is a beautiful thing and has emergent properties as a whole, which of course it does, because if you cut the elephant apart, then it's quite difficult to put it back together again and expect to see it work. There are a couple of other alternatives in terms of how to deal with this issue. One is to throw sand at the bull in an attempt to blind it. And Pirsig, in his logical journey, avoids going towards mysticism as an attempt to do this. So this kind of obfuscatory concept. And the fourth is to stare the bull directly in the eyes, to use logic in attempt to understand this apparent disparity between the left and the right horn. As a way to then try and grapple with this problem, this is a chap called Ian McGilchrist, tricky name to pronounce evidently, who talks about the divided brain. And his proposition is that we need to understand the world initially through right brain, so the ability to connect things together and understand this kind of possibly what Pirsig might have described as being a kind of a patchy, mystical reality of outlines. And then we would go over to the left brain in order to put things into their place and understand them in their position. But then would need to go back again to the right brain in order to assess, well, have I really understood this thing as a whole? So there's this complex dialogue between the left and the right brain that's necessary in order to understand the complexity of the world in which we find ourselves. And one of the things that McGilchrist says is that if we are overly reliant upon left brain thinking, this engineering-ish, reductivist view of thinking, then the likely scenario is that we'll be this kind of blind person whistling a merry tune as we walk off a cliff, which actually doesn't seem that far away from where we find ourselves with regard to certainly the healthcare system, if we think about the fact that within many Western economies, then the cost of healthcare will exceed GDP within the next 10 to 20 years. Certainly it's unsustainable. So the question is what to do about that. Another thing that McGilchrist is very keen to point out is that specificity is always obfuscatory. So our desire to, and now he seems to be going into a rave or something, I'm not quite sure what's going on there. Specificity is always obfuscatory. So there's this kind of awareness of almost this kind of quantum level of uncertainty, and the more that we know about a particular aspect of a molecule, the less we know about another aspect, and that might tell us something about the way in which we choose to manage and measure systems, for example, systems of healthcare. And as I'm talking to the Society for Cybernetics, I was reminded of the cliched fact that the etymology of cybernetics is steersmanship, and it seems significant that actually there's a possible weight of responsibility on this group of people for being able to manage this apparent disparity between the left and the right horn. And I also questioned whether in organisations is really the right moniker for the fragmented economy in which we find ourselves. So with that as an introduction, I almost feel compelled to backtrack slightly to say, well, actually this is about an exploration of health as an ecological concept as opposed to defining what an ecology of health is. Because in a sense it's very easy to define objectively when you have singular linear measures. When you can say this is either more profitable or less profitable, it's very easy to work out which one is the more profitable. But if we consider that most of the top companies in the world would not actually be profitable if we took into account their ecological and social impact, then is that really an appropriate measure? So actually we've got this view of economics as being a sort of a perfect arbiter, and actually this kind of hazy view of something else which could possibly be an alternative. And if we think about sort of political rhetoric, then is it reasonable that we should suggest that either the options are left, fat, bureaucratic, costly, or right, austerity and cuts? Could there be alternative models that are tenable? It would seem ridiculous to assume that those are the only two possibilities, and yet that's where we seem to find ourselves. So we start with this view of market economics, and I'm not going to go into market economics. I'm sure that you've already got your own views as to how effective it is as a way of managing systems. I could talk a little bit about my own view of market economics with regard to the healthcare system. And I could say that I started a journey in a large commercial provider who looked at long-term conditions as a big problem. So if we take type 2 diabetes, there's apparently a £10 billion problem which will double in size within the next 10 to 20 years, and from the perspective of this large corporate provider, this is then a £10 billion opportunity. So if we regard the purpose of the system as what it does, then this £10 billion opportunity of a market becomes very attractive. I didn't really think that was the right thing to do, so moved to the NHS and actually found that parts of the NHS were seeing this £10 billion problem as a £10 billion opportunity and then trying to sell their solutions to other parts of the NHS. And the fact that the NHS also has a £14 billion internal market that achieves an output of, as far as I can discern, nothing, then it doesn't appear to be a perfect example of equilibrium or the market dictating perfect economics. I suppose if we take a bit of a jump, and I probably have to say at this point that in this concept of ecology, that a lot of these ideas are owed to the work of Gregory Bateson and the Bateson Institute, of which Nora Bateson and Aidan Ward have both played significant roles, not played significant roles, played significant roles. But if we look to Andreas Weber's recent work, then if we accept that this idea of market economics was largely based on Darwinian views of competition, then there's this big question mark about whether Darwin's ideas were really an accurate reflection of the biological systems in which they were rooted, or actually were they a more accurate description of Victorian England, or pre-Victorian England, where he observed these conditions. So actually, if we are to understand a more advanced view than market economics and that sort of singular notion of supply and demand and equilibrium would assume, then do we perhaps need to take a different view of what Darwin was perhaps trying to say, and perhaps what he was observing? So there is perhaps a different view as to what that could mean. we talked a little bit about the healthcare system. If we sort of start from the assumption that it's about hospitals and doctors and nurses, then we could also extrapolate that definition to where it finds itself now. So from a cost perspective, it's well evidenced that intervening early on would hypothetically be a lot cheaper than dealing with people when they have multiple comorbidities. However, there's a big assumption that it's possible to intervene early on. And that people will respond. And of course, if the purpose of the system is what it does, then a system which is geared to illness is geared to seeing illness. A good example of that would be the National Diabetes Prevention Programme. So about a third of the adult population is now termed to be pre-diabetic, which means that they have impaired glucose tolerance and are at risk of developing type 2 diabetes and other comorbidities. So if we see that third of the population as being pre-diabetic, then there's a need to medicalise that and do something about it. And a question mark about whether doing that actually supports people to not be pre-diabetic, or does it stigmatise them into a condition? I don't know, but it's a question. The University of Oxford found that this multi-million pound diabetes prevention programme didn't deal with effectively the complexity of the situation in which it found itself. So it's effectively saying that it's paternalistic, it's top down, it tells people what to do, and it assumes that they will all behave in the same way. So I suppose then back to this Weber question then of can we really assume that that science, that doctors, as the measure of all things, sit as the hierarchical tumult of our health system, or do we perhaps have to accept the fact that we are part of an ecosystem, and within that ecosystem? One of the unpublished papers of Bateson's talks about the system map of man interacting with deer, and in a kind of historical concept, there being a very, very short feedback loop, in the sense that you've got man observing deer, deer interacting with man, and then you put in place levels and levels of abstraction from that deer, and man becomes effectively a completely separate entity. Whether he's then able to, or humankind is then able to really interact with the fullness of what the deer is, then becomes quite debatable. And then when you put in place tools and weapons and processing, then we abstract ourselves away from this vicariousness of interaction with that animal. So a big question mark about whether that really helps us to be a part of the system or abstracts us from the system. Perhaps a good example then of how this plays out is bees. So if we take the evidence base, then there's a lot of famous publications that refute the impact of DDT on bee populations. And in fact, it has been proven that even safe pesticides don't kill bees. The issue appears to be that even safe pesticides destroy bees' memory, which of course they need for communication, and they need for complex navigation, both of which they require in order for the hive to function effectively. And of course we actually require bees and their ability to pollinate in order to survive as a species as well, so that's a problem. But actually our emphasis on whether it does or does not kill the individual is an interesting analogy for how we perceive healthcare, particularly when we think about pharmaceuticals and the extension of life at what quality. So this question mark over how we preserve bee populations as a collective entity, and where are we actually seeing the quality in that. There are lots of great public health examples, but here's one. That's the three main ingredients of breast milk, and lactose and fats should be reasonably obvious to you in terms of the physical benefit that they provide, but these oligosaccharides less so. So actually they're not processable by your human cells. They actually go through your stomach and processed by the lower intestine, where the majority of bacteria lives. So actually it would appear that the third most prevalent ingredient in breast milk is not for processing by human cells. Which may at some level be obvious if you were starting from the assumption that we need to feed bacteria in order to be healthy. And though the views in terms of what percentage constitution we are of bacteria vary, we're certainly more bacteria than we are human cells. So the idea of feeding only our human cells would seem to be questionable. But then if we extract that into formula, then there's no reason to provide this nutrition in order to support our human cells based on what we assume ourselves to be. If we make a bit of a jump back to the healthcare system and back to this sort of economic view of demand, the best way that I could represent it was that you could go to your primary carer, your GP, with any number of conditions, and there's a kind of a clouded environment there, which illustrates that the economic view of, well, if I've got a service which is free at the point of delivery, then it will be met by unconstrained demand and therefore will be swamped. And so how I respond to that is by having a gatekeeper that effectively stops people from accessing expensive downstream services. But effectively what that means then is that regardless of what your long-term condition is, I'm not talking about necessarily if you get run over by a bus as you step outside and then get picked up by an ambulance, that's a slightly different pathway. But outside of that, it's pretty much, regardless of what your condition is, you will have a 10-minute appointment with a GP. And a question is, does that give the requisite variety needed to address every kind of healthcare condition? I would suggest that a single response would suggest probably not. So actually this kind of idea of the perfect market starts to fall apart, and you know, this idea of the multiple hospitals that we choose to build in order to deal with this perception of limitless demand versus the reality of placing supply and interpreting demand in the wrong way perhaps leads to this significant imbalance, which is not a cost saving at all. If you add to that dynamic, then a lack of information exchange across care settings. So if you've been to see a GP and then you've gone to hospital and you come back again, how many people have found that their record has been updated when they've gone back? Is it being up to date and it's contained relevant information or not? So up to date, Hans? No? Not up to date. Okay, so the vast majority of people are choosing not to say, but there's certainly more not up to dates. Huh?
Don't know.
Don't know. Okay, don't know. That's a permissible answer. Never seen it. Okay. So lack of information, certainly from your perspective then, so a lack of information in terms of what your clinical record incorporates, don't know is the answer. Possible language barriers, so actually do you speak in the same clinical language as a GP? Do you actually even speak in the same language as a GP, question mark. And added to this fact, everybody has access to Google and of course is now an expert in their own condition. Does that present an additional challenge in terms of helping those two sides to have a sensible conversation? This is an example from some work that Aidan and I actually did in sickle cell. And you can see the GP there, this apparent gateway of care, out abandoned in a corner. And what we found from sickle cell patients is that they never go to see their GP if they have a sickle cell related illness or sickle cell related issue, because they don't have the specialist understanding of what the requirements are for sickle cell. So actually what this is illustrating is that these patients weren't following the pathways that had been set out to them by the commissioners. In fact, they were following completely different pathways. So there's that kind of picture, and maybe I should have put it in, where somebody's built a path which they assume to be the right path to the hospital, and then people have sort of taken the more direct route, and there's this kind of worn walkway through the grass, which is actually the reality of what we're seeing. And particularly with regard to specialist high-cost conditions like sickle cell, which is one of the most expensive conditions that you can have, then that's kind of interesting in terms of the majority of that cost not being seen anywhere near primary care. So there's a question mark then. What is the responsibility of the commissioner? So is it about defining an objective pathway that is known to be true, or is it something else? And I had this conversation with several commissioners about sickle cell, and effectively the logic of the argument went along the lines of, well, yeah, I understand that it's about everything else other than health. Actually, it's about social needs, it's about whether somebody knows where their next meal is coming from, it's about their employment, and so on. But actually, that sounds a bit complicated, and it's not really my problem, was effectively the conversation. You're talking to sort of bright, intelligent people, and it seemed quite underwhelming to me that would be the case. And you add on to that paternalism. So this is a patient activation score, and as you can see, it's got 4 levels, and it's got an arrow which pushes people to the right because they have an increasing level of activation. And it says that level 4, maintaining behaviours and pushing further, is better. And I wonder if you take a moment to think about how you would respond as an intelligent, authentic, empowered human being when faced with that kind of interaction, whether that would really represent the variety of you sufficiently. And does everybody get pushed to level 4 and then stay in level 4? Or is that actually a very complex process that's affected by multiple different things? So as an alternative then, do we actually envisage primary care as this kind of coaching mechanism that enables people to interact with their environment in all of the complexity that entails? So actually we accept the fact that people will have multiple needs, that those needs will be expressed in different dimensions, and actually instead of the GP, if I go back one, being this kind of blocker in the middle, does the GP actually become an enabler? And actually then is a GP an appropriate enabler for this type of interaction? And if we were to define what their role is that about helping people to find meaning of this complexity or from this complexity? Well, actually, that's called social prescribing. It's been done, and there's an interesting example of Bromley by Bow, which is now very famous, which is one of these kind of 30-year overnight success stories. So actually, it started more than 30 years ago, with the founder effectively going out and talking to people in the community and asking them, what do you want, and what can you do? Which would seem to be 2 fairly basic questions. And then subsequently they developed that into a medical model in which people selected their own GP. So it wasn't condition specific, it was actually, I can relate to you as a human being. And then their families could relate to that person as a human being. So actually it's quite a different example of how do people think about social requirements and social determinants for health. They also do all sorts of other things. So there's a question mark over whether if you're about to develop a long-term condition in 20 years' time, but you don't know where your next paycheck is going to come from, then does that mean that you're going to have the right level of dedication towards that end goal? Well, actually, we probably need to fix that proximate problem first, and a GP is probably a bit expensive to do that. So do we find a lower cost resource to do that effectively, and can that be done in the community? There seems to be some jumping around of slides here. I'm not quite sure why, but anyway, We talked about type 2 diabetes, and we talked about the National Diabetes Programme. And I talked about why it wasn't seen to have worked perhaps as well as it could or should have done, or isn't working as well as it could or should have done. And I think we've covered most of these points. So actually what it's really saying is you expect a 25% reduction in the rate of type 2 diabetes, but what it's also saying is from this critique, we weren't able to accurately identify who the people were that were likely to have type 2 diabetes. So we've identified some people that are not at risk, and we've put them through the programme, and then we've also missed a load of people who are. So even if it works, then we're misdiagnosing. On the other hand, and this is it's been published in the Daily Mail, so it must be true. Type 2 diabetes has been proven to be reversible by studies from Newcastle University. So putting people onto an 800 calorie a day diet for 2 months actually reversed the symptoms of people with type 2 diabetes having experienced those symptoms for a number of years. So that's interesting, and it was a small study, so I don't think we could say it's generically representative of anything, but it's interesting. 800 calories is not a lot. So one of the pieces of feedback from that study was that actually it was pretty unpleasant, and one of the main issues that people had was boredom, because they go from a full diet to having a couple of nutrition shakes a day, and actually got really quite bored during this process. So question mark, if we kind of go from this kind of full diet to a couple of nutrition shakes a day, and then we have to deal with this boredom that accompanies it, then does that also present an interesting analogy for where we need to find ourselves with regard to health? And then the second thing is maintaining it. So the people from this study did. But of course, one of the issues from crash diets is that most people then go back into a context in which they found themselves, in which it was socially acceptable to behave in a certain way. A lot of studies on addiction illustrate a paradox of two things. One is that when people are abstracted from their context, so they don't have social parameters around them suggesting that they should behave in a certain way, they are much more likely to become addicted, which perhaps is not surprising. But of course, when people then are rehabilitated and then go back to the social context in which they found themselves, then they're also likely to get re-addicted, because of the fact that it was the social context that determines their addiction as opposed to themselves as individuals. So question mark in terms of if we were going to look at this as a shining light in terms of how to manage one of the biggest cost issues in the healthcare system, then would that be an appropriate way to treat people as individuals? And I think back to Persig here, so he sums it up much better than I can, but effectively it is kind of saying that after all of these definitions of quality as an objective thing, the question mark of this romantic whole system view with the engineer's reductive view, actually if we boil it down, the idea of sitting objectively and being able to assess these questions is ridiculous. So actually we don't sit as individuals is partly what he's saying, and if you were to look back to that ecosystem view of the human sat in the middle of this complex morass, that's much more accurate as a reflection of what Persig's saying here than man as the measure of all things. And it seems very resonant with Gregory Bateson's work. And he describes our perceptions of reality as small arcs of larger circles. So if you were to imagine a tree as a projection into our awareness, and ask a tree to differentiate between its leaves and its branches and its trunk and the exterior environment, and you could communicate with that tree, then I suspect that the tree might find the idea of distinguishing between those things quite ridiculous, because they're all needed for its survival. In addition to that though, our perception of the tree, the crown, is necessarily smaller than the roots in order for the tree to stand up. So actually we're seeing less of the tree than exists. But actually we've proven that trees trees exchange nutrients with other trees. We've proven that trees exchange poisonous substances with other trees, and we've proven that trees are much stronger within a system of other trees than they are without, which possibly from our human perspectives might be why we consider that they do those things. So if these kind of tall, pointy projections into our awareness, trees, are connected in ways which we previously hadn't recognised, then might that also apply to humans? Are we also connected in ways that we haven't recognised? And how might we communicate in different ways so as to understand that communication that's taking place? And again, I think that this idea of the sort of the small arc of the larger circle, our perception of visible things, is quite an apt reflection of that idea. So I guess if we kind of fast forward from Pirsig into Glover, who then sort of reinterpreted what he said, then there's this question of quality, which possibly can only be understood through analogy. So I kind of go back to the earlier statement of this question of we've got this very clear view of the economic view of health systems, and this very unclear view of what could an alternative be, and we need to become more comfortable with accepting this unclear view and balancing that with this kind of objective notion of economics. And I challenged myself to then find an analogy, and this one of the candles seems to be appropriate. So the objective form of the flame remains almost the same, but the molecules that are passing through the candle change continuously. So as it burns down, then actually the candle is not the same set of molecules. Similarly, actually the molecules that inhabit you as an individual continuously change. So not necessarily at a cellular level, but at a molecular level, you are changing constantly. So actually this idea of this kind of fixedness, of this plantedness of ourselves as individuals that only respond in a certain way, that get to level 4 on patient activation score, seems to be an outmoded concept. And I'm reminded of this quote by David Zygmunt that talks about good personal health care. So he says, if you want good personal health care, see a vet. And of course, animals can't communicate directly to humans through language. So why would a vet be able to provide better personal health care than a doctor? Well, is it that through creating these multiple layers of separation and our communication through singular language, that actually we've lost the complexity of what it means to deal with a human? So to leave you with a couple of things then, where Weber then goes is saying that the biosphere is not connected in linear one-to-one simple connections. So this idea of being able to present to a GP, having a 10-minute appointment, that's moved me along, possibly up a level in terms of my activation and going away, is not the way that the biosphere actually functions. So it's a misrepresentation. And actually symbiotic relationships emerge out of these antagonistic, incompatible processes. So they are paradoxical by nature. We may well take 2 steps forward in order to take 2 steps back in order to take 1 step forward at times. And we perhaps have to be able to accept that we exist in this morass in order to reflect the true nature of our own health and our health as collective systems. And I think where I want to end up is this quote from Pirsig then about good. So after all this work on metaphysics of quality, in which you'll probably remember that the main protagonist, Phaedrus, which was an autobiographical representation of Pirsig, went insane and had to be submitted to electroshock therapy in order to try and rationalise these 2 perspectives, says that actually good is about as accurate a definition as we can get to this objective notion of quality. So what is an effective healthcare system? Well, it's good. But as a nuance of that, this collective definition then becomes really important. So it's not good as a singular entity or good in the sense of a verb or an adjective, but it's good as a collective noun. So we can negotiate together what good means, and then actually we can cut away quite a lot of the pseudoscience that tries to objectify what good is, and we can agree that that's what the healthcare system should look like. So I kind of come back to that as being the culmination of really quite a lot of work that says good as a collective definition is about as close as we can get. And a question mark then comes in terms of, well, what size of entity would determine what good looks like? Well, the City of Manchester would seem to be a very large size of what good looks like. Is that too big? I'm not sure. Can the whole of England decide what good looks like? Would it have to be defined at a global level? Or actually, do we need to see communities of people defining what good looks like for them and then taking collective action towards it as a way in which to shape what healthcare means for us? That's all I wanted to say. Thank you.